My name is Mary Krasner, and I am a co-founder of NYC FAIR. Our goal is to have this town hall be a conversation, not a presentation. We have received a great many questions, probably more than we can get to, all of which came from the registrants. We've condensed those that came up over and over again. Some of those who registered do not know a lot about the CAS, and some know a great deal. We will try to address both audiences as best we can. All of the panelists received the questions in advance so they could see what stakeholders' concerns are. Even if we don't get to them all, it's useful for OPWDD to have them as a window into the confusion and anxiety around the CAS. I'd like to start out by saying that the federal government requires that the state agency responsible for disability services, in this case OPWDD, must do an assessment of everyone receiving services. Now I'd like to introduce the moderators and panelists. There isn't time to share their full bios. We will send them after this town hall. I'm including only the most relevant information. The moderators are Rachelle Kivanoski, a parent and a member of the Executive Committee of NYC FAIR, and Carlene Braithwaite, also a parent and a member of the Executive Committee. Both Carlene and Rachelle serve on various committees and boards of organizations dedicated to the well-being of people with IDD. Excuse me. Karen Azarian is a sibling of a brother in certified housing. As an advocate for him, she is a member of the Legislative Committee and CAS work group of Care Design New York, the Individual and Family Advisory Board. Michael Seereiter is the president and CEO of the New York Alliance for Inclusion and Innovation, which is a statewide association of nearly 130 not-for-profit agencies serving people with disabilities. In his prior career, he's had several positions within state government focused on mental hygiene services. Michael is also a sibling of a brother with Down syndrome. Mike Lawler is the Chief Program Officer for the New York Alliance. Mike joined the Alliance 3 years ago following 25 years in state government. He currently oversees state and federal regulations, finances, quality compliance, federal advocacy for the Alliance, and is also the association's lead on the CAS assessment. From OPWDD, and these are done alphabetically, so please don't take offense if I've gotten your positions within the hierarchy wrong. Jeanne Cavanaugh, who's the Assistant Commissioner of the Division of Statewide Services. Al Pruett is the Director of the Bureau of Assessment Oversight, and Stephanie Ostrowski is Director of Operational Oversight and Review Division of Statewide Services. Thank you all for being part of this. I now turn it over to Rachelle for the first questions.
Hi, everybody, and it's good to see everyone around this virtual round table. Anyway, we're going to delve right into the first part of this discussion, which is how the CAS, the assessment, is administered. So we're starting with the process because many families feel that they're very confused about the purpose of the assessment. They don't know how to prepare for the assessment. And after the assessment, they're not entirely sure how to interpret the results of the assessment. And we know that OPWDD has delegated the central role in all of this to the care manager within the care coordination organization. But people still feel very at sea. So I guess I want to start with some particular questions that come up. The first one is, in the recent CAS education sessions that OPWDD conducted statewide, it was clearly stated that people are supposed to be offered a choice of in-person or virtual or telehealth assessment interviews. And I can tell you that many individuals, families, care managers, and even assessors seem unaware of the in-person option, even though it might be most likely be a better option for many people who don't do well with screens and would result in a better quality information. So first I want to just ask Karen, as sibling who attended her brother's CAS. Did you think the in-person format actually was a helpful format for your brother?
I did. I believe the initial assessment was virtual, but the reassessment was in person. And I found that the assessor was able to get a more rounded impression of how my brother interacts with people. So I was glad that she had the opportunity to do that. And she was also able to see much more of his environment than she would have otherwise. So I think it is important.
Yeah, that was my experience as well, contrasting the two types of assessments. So, the first particular question is, how is OPW making sure that this choice is being implemented in reality? And are we instructing care managers to help people make that format decision in an informed way? So that's question number one for OPW. Al, you don't have to raise your hand, Al. Just talk.
Thanks, Mary or Rachelle. So I've received some feedback with similar question and concern, and of course, we heard this was brought up during a number of our presentations that we conducted around the state in person. And one of the things as a starting point that I wanted people and families to know is that this, of course, does remain their choice. Okay, so from a starting point, we need to I'll say you're probably going to hear me a number of times say this, but take that village approach to sharing information so that people are empowered. They know what their options are, and then they can advocate for those choices that they feel are best aligned with their need and their family members' needs. The second thing is that we, of course, have a number of scripts involved in our workflows, one of which is a scheduling script. And I personally was involved in the development of that script, including the addition of the telehealth modality. And so when I heard this feedback, I was, of course, aware that we should be always our schedulers should always be offering both options. So when I dug into this a little bit further, I found that the order that was often presented was, would you like to have a virtual assessment or an in-person? And I thought, you know what, let's take an extra step here to make sure that people are hearing us and that they're getting this option up front. So we flipped the order. We said, let's make sure that they're offering in person. They're leading with in person because we think in person is a great option. We share, I'll say I share some of the opinion as well that it might be better for my family member personally and for our family. But I'm also keenly aware that we've received a lot of input from advocates, from families, from people we serve that say, we don't want in person. It's too disruptive to our household, to the person. This type of interaction we're all having tonight is their preference. So I think there's something to that. But from a starting point, I want you to know that it's in our scripts. We then went to our training resources, and we made sure that care managers are well informed. So to your point, we wanted to make sure that they were, Karen, to your point, we wanted to make sure as well that care managers are aware and that they're not just aware that we're offering an option, but that they start to think about engaging in that discussion so that people can make more informed decisions. Because on the surface, you might say, I think the video is going to be easier for us, but we want them to consider the interaction, perhaps the quality of the interaction, perhaps the sacrifice, bringing someone into your home, or scheduling at a location in the community, albeit an inconvenience or a challenge, perhaps with transportation, may add value in the end. But that's really a person and family's choice. The next thing that we did was we've been working with the Alliance on a lot of these topics, thinking about providers and preparation for assessment. And so we knew off the top, first thing we have to do is socialize the understanding that people need the supports need to think about the people that they're serving, and have internal discussion as well as discussion with circles of support there to make sure that decisions that are being made are aligned with people's needs. So, I think where my head's going now is around schedulers are reaching out to a primary support to initiate scheduling process. They're often reaching out to, at least in our residential programs, our residential providers to help with that scheduling process. I'm kind of curious, or would like to volley it to back to our friends at the Alliance and just kind of pick your brains a little bit too. Have these been discussions yet that have come up in your in with your providers, or in discussions with some of the providers that have been sort of working to do better in some of these areas? What maybe guidance is in place to help inform their staff related to preference and modality, and how to help people make really well-informed decisions?
Actually, I'm going to stop it there for a second. Yeah, Mary has her hand up.
Yeah, I would just ask, for my own benefit, to use the word socialize may not be clear to everyone, certainly not to me, exactly what that means. And by modality, you mean choices. The plainer the language, for my benefit, if no one else's, I appreciate that.
Sure. When I say modality, I'm actually referring to whether the person would like to choose a video like we're having tonight, in type interaction, or if they would like to have the in-person, like face-to-face in person. I apologize. That's what I meant by modality. By socialize, what I mean is to increase awareness, or to familiarity, to help everybody recognize and be aware of what happens and how it happens.
Okay. I actually want to interrupt for a minute before we get to the provider side of this, which is, the assessor side. And I do wonder if there is not some incentive for the assessors to choose the virtual format. It's less commuting. I don't know how they get paid, whether, but do they have an incentive to, kind of push forward that format?
I wouldn't think so. In fact, I'd probably go the other direction. When we started, of course, prior to COVID pandemic, all of our assessments were being conducted in person. Assessors appreciate that interaction, as I think I heard you have as well. I'll just pick on Karen, but I think our assessors give us good feedback about that. For them, if you if you think about it, being out in the field is not really an inconvenience. It's a nice opportunity to get out of the office and take a drive over to the other side of town, and sit with some people and have a conversation and complete your work. Sometimes I think telehealth, or use of this new video format of interaction we have is somewhat grueling for us all, because we can line up appointments sometimes too close together and not have enough time to take a break and breathe. I miss the days when we used to jump in the car and all go sit face to face with each other. And so I appreciate that type of interaction. I think a lot of our assessors do as well. No, I think it's just the opposite. I think that just
Oh,
as
I
you
think,
hear,
yeah, Al, I think we got
Mary,
it.
yeah, I'm sorry, Rachelle. Yeah. Let me add one more piece to that, though, that, just as we hear in workforce that people are struggling with going back to work, I think people and families find a lot of convenience in the video facilitated interviews.
No, I can understand that too. So Michael, do you have something to contribute on this in-person versus virtual discussion?
I'll
Oh,
take it.
okay, Mike, yes.
That's all right. We go by either name. I think the basic message that we have been trying to have with our providers, as we've talked about the assessment, is making sure that the individual knows their choice and what's going to be best for the individual in terms of their comfort level when doing the assessment. I think the other thing that we have really been stressing is to make sure that they have the right people around them when the assessment is being scheduled to be conducted. If you're in a residential program, having the right person that spends the most time with you being a part of it. So that's been our basic message of working with the providers, to get them to understand the importance of the assessment and making sure that the individual who's being assessed is comfortable and takes the approach that is the most useful to the individual.
I would, we're getting some feedback from some providers, particularly day hab providers, that they're not always thought about in terms of including them in the process. Would that be your observation?
Yeah, that's been discussed at the Provider Association meetings with OPWDD a little bit. I think that there's an opportunity there, but I also think that's an opportunity for care managers and family members to make sure that the right people are getting involved in the process itself. Like I remember very well with my brother's process, it was we were explicitly asked, like, who else should be who else should be involved in this assessment? Who else needs to be part of this process? And that's, I think, incumbent on everybody to make sure that everybody's got an opportunity to help make sure we have a well-rounded view of this individual.
Okay. Well, I'm actually very happy to hear that we're all on the same page for that. Although I will ask you, Karen, do you see any downside to possibly having too many people at an assessment? No, I'm very serious about it, because I actually have some concerns about that.
Yes. So we have involved close family and the house manager in my brother's case. The care manager was not participating. It would be very interesting to see whether the Prevoke staff, for example, would have wanted to participate, but scheduling is so difficult that to involve more people would make it very, very difficult to schedule. So I don't know how that would be. The one factor that I guess I don't think I hear talked about enough is how much time is dedicated to the assessment. Because I feel that in the scheduling, it's kind of assumed that we can get through all those questions in an hour and a half. And there's even, it seems the assumption for reassessments that it would take shorter than that. And in my experience, that has not been the case. And especially when my brother wants to participate or he must self-report an answer, there's really not enough time given to that.
Now, shortly, because I have to move this along.
I feel like it's helpful for people. Please visit our website and review the information on there. I can't take all our time tonight, I know, talking about administration process, but I think it's super helpful for people to know that this is a multi-step process. with multiple sources of information all being utilized to ultimately complete the assessment. So when you think about participation of any individual, it should be looked at as the potential for a separate, discrete interview. So for Karen's example, with her family member, that's one piece. Then we also have the opportunity to incorporate additional pieces. And I think to the point, and Mary, or I'm sorry, I keep saying Mary every time I look at you, Rachelle.
Okay.
To your point, when you start to think about the care planning meetings of yesteryear, the big treatment team meetings, it's everyone sitting around a table, and I feel like the individual voices can sometimes get drowned out. So this is a very intentional process that we walk through in our administration protocols. There's also a substantial documentation review. So in terms of the allotted time, um, there's ample time for the individual, there's time for the family member, there's time for the provider. And when we start to worry about every single provider having opportunity to participate, I want to remind everyone that needs are needs, right? And my needs are my needs across service settings. And when there's significant differences in those needs, we need to understand that. But that doesn't mean that we necessarily need to go to every provider and explore needs, because needs are foundational, and what changes between different service settings, we could talk about this, is often related to behavior, right? Behavior is probably one of the most significant, most dynamic aspects of our need profile. Other than that, my toileting, my ambulation, my eating are transferable to, so to say, across service settings. How that's actually supported becomes care planning. And so that's where I would encourage the pre-voc and perhaps the day program and the ComHab and the other providers to get together, to put their heads together, and then compare how the need is supported perhaps differently across those settings. But that's really care planning in my mind.
So I think I'll allow if the mics would like to respond to that quickly or not. No? Okay, so then we could consider ourselves somewhat in agreement, I guess. So there were a final question is, what is OPW doing to help the care managers' understanding of the process so they can better help all of us? You again, Al?
Thanks.
Okay.
I'll take it. I just spent a lot of time working on this, so it's fresh. We've done a number of things over the years, from pre-CCO with our MSC agencies through current day CCO and care management. More recently, we've taken a number of steps to help support better experience, better outcomes, better utilization of the information, and really more of an integration of that within the comprehensive assessment and care planning process. We recently partnered with all CCOs to really take a deep dive into each of the process steps from the beginning of CAS through the utilization of it in care planning, and even through a concerns review process. And we built a 5-module training with them. We reviewed it internally with our CCO leads at central office again, and with other SMEs, and are really excited to get that product out. That's out there and available now to care managers as well. They had their own curriculum, and we've reviewed that, at the birth of CCOs. But we knew that there were new areas that we need to zoom in on and do better at communicating so that we could bring new care managers up to speed faster, and so that we could address some of the issues that we were hearing about today, right? So I'm excited about that. That's not going to be a static training. It will be dynamic. We'll be able to make enhancements to it as needed. We can also add additional modules or sort of sub modules to it as well. So I've already got our teams, drafting materials to review with CCOs, and it really is a partnership. I think that's going to strengthen the quality of this and the the utilization of it. So I don't think it's going to sit on a shelf. I think we're going to do very well with that. So that's one of the things that I wanted to share. We are doing with CCOs.
I am happy to hear that. I did know that, of course. I just gave you the opportunity to tell other people. But I will also share with you and give you and offer a suggestion. I actually sat through the modules myself to see, what the content was. And I have some suggestions for you. So I think you need to think about including perhaps some individuals and family members into your education planning to see what maybe there are areas that you're not thinking about that might have a significant impact on how this happens. So just a thought for the future. Okay, so I'm going to move on now to some particular questions of concern, and I'd like to do this a little, how in the debates they do these lightning rounds where you get to answer very briefly. So I'm going to see if we can do a little lightning round on a few of these, okay?
Briefly is a great word.
So how does the one question is, how does the CAS capture events that may not have happened in the last 3 days, but do occur in a person's life and are very important, things like behaviors and seizures?
Present but not exhibited. So we absolutely have the ability. 3-day look back is a conversational style interview tool to really collect information about things that happen every day. And I know some of you have been to our presentations, so you just heard me say these kinds of things. But for lightning round, I'll say, things that are not every day occurring, such as life events, behavior, health needs. We start from a very simplistic present or not present. Okay, so you don't have to rack your brain. Was it last week, last month, last quarter, last year? Present.
Okay.
Even if it's being managed, if it's being supported or not, it's still present. You de-escalated the behavior, so it didn't occur, but the behavior is still present.
Okay, so that brings me to my next question, which is, does the CAS account for the psychological needs of the person and not just the hands-on care? The need for reassurance, coaxing to participate, behavioral support, anxiety with new tasks, et cetera, et cetera.
Yes, it does. So I'll start with from the interview process. It sure does. We have a lot of training in interview skills to help support assessors and understand communication styles and needs. We also check with those who know the person well. As an extra step is to understand and be aware of needs that may develop through the course of the discussion, as well as following the discussion. I think that kind of is very appropriate when you're talking about the fact that when you have in-depth conversations with people, you can stir things up, and the person may need additional support in the days that follow, perhaps if it stirred up some things for them. But when you're talking about actually in the assessment, does it account for these things? Does the assessment itself account for these things? I think you have to start by thinking about some of these specific examples you gave me. So one was psychological needs. Okay. Can you expand on that for me a little bit more so I can kind of grab onto something and work it through the assessment?
Well, one of the purposes is to understand how much support people need. So if you have a person who's extremely anxious and needs to have that kind of reassurance and support through every step of a process, whether it's getting dressed in the morning, getting on the bus or the train, however they're transported, going to a class, that kind of support that people need that, in my experience, is I didn't see necessarily addressed.
Okay, sure, that makes sense to me. So what the assessment does, and I heard a psychologist from out in central New York explain this very well to us. So I steal his example often in these types of discussions. The CAS will have a number of very important points throughout it. So let me give you some examples. You used anxiety. And I might add to it that there's an item that looks at whether the person is late for work or having issues with employment, if they initiate involvement in structured activities, if they need support with getting dressed, if they have certain diagnoses. So what this psychologist had pointed out to us that he thought was a great characteristic of the assessment is that we don't try to connect the dots in our assessment. That becomes the role of the care planning team and the circle of support.
Yeah, I don't think I think we're talking a little past each other, so I'm going to move
Okay.
on at this point, okay?
All right.
Because that wasn't really the essence of what I was trying
It's making a point
to
there.
get at. So one of the questions is, how many does the number of hours of support an individual receives from their family, is that information used to increase or decrease the number of direct care hours the person is determined to need? OPW? Anybody? Yes, no?
And the answer, no. And the answer would be no, in short, because I'm thinking we're still in the lightning round.
We
So
are.
if not, let me know. But no, it's not going to, what Al said before, and I try to keep this simple. The need is the need, regardless of how it's supported or who supports it. We have to acknowledge that that is what we are there to talk about. We have to know what a person needs and whether it's supported. A lot of people are concerned about natural supports versus paid supports. And does that matter? It doesn't. We really should acknowledge that the person has the need and they're going to need support around it. So I kept it very brief, very quick, but I hope that helped.
Much appreciated. Thank you, Jeanne. And another quick question. How often are the assessors assessed for the competency and accuracy of the assessments? And by whom?
That would be by us. We provide quality oversight of the assessment teams as well, both the state and contract vendor Maximus. We were performing annual observations of these assessors. So in our field observations, we watch them administer assessments. We look at the coding of the assessments based on the information provided in the interviews and the documentation. That was an annual process. We did pause that for a moment as we've been ramping up activities with CANS, but we have since restarted that program and will again work to get every assessor observed every year. And we were doing 3 observations for each assessor. It's also important to know, Rachelle, that every assessor is very closely reviewed prior to entering the field. And then we have that additional annual observation and quality check. We also do desk audits. So we're also able to look at inter-item agreement, or we look at their assessments as a whole with supporting documentation and also look for cross-item accuracy. So we also have that desk audit option that we utilize with assessors, and that's ongoing. That's ongoing. Whenever concerns come in, we also look at assessors' performance across their work.
Great. Thank you very much. That was very clarifying. So I'm going to move on now to the issue of transparency, which has been an area of concern for many. And many individuals and those who support them would like to get copies of the questions ahead of time. So we're not asking for answers, they're asking for questions so that they can prepare and provide the most accurate information for the assessor. The current long assessment process is also actually very anxiety inducing for people, for the person, for their supports, for everybody involved. And having those questions in advance could alleviate some of that anticipatory anxiety, shall we say. Also, the CAS has been said to be replacing the DDP-2, which is now used for baseline program eligibility and self-direction budgets. And the DDP-2 questions are readily available. So then the question arises, why shouldn't the CAS questions and potential answers also be available to anyone requesting that information? And when I said I didn't mean the answer is provided by the person, but I think people would like to know what the potential answers are, because they're usually a multiple choice and the assessor picks one. It's not an essay. And so these are the things that keep coming up over and over again. And I guess my question is, why can't this happen?
I'll take it. I don't know if I can do this in lightning round. You're just gonna have to interrupt me.
It's not the lightning round anymore. It's a topic.
All right. You know, Interai's chosen, obviously, to make their intellectual property available for purchase. And New York State is under contract with Inter-REI to be able to utilize their assessment, which doesn't include copying and distributing their copyrighted information. You know, I think it's important to always go back to the fact that assessors go through extensive training to ensure consistency with interpretation, definition, and intent. We don't want to put that on families, nor do we think that every family would benefit from this. So, you know, I guess when I hear these types of questions, the first thing I think is like, yeah, my family would probably appreciate this too, and might want to read it up on it and study it and do everything they can because they're very invested in making sure we get the appropriate service and supports we need. But I don't know that I actually agree and believe that this will result in less anxiety or being better prepared for your assessment. I think the best way to prepare for your CAS is not by studying the tool and knowing what the options are, because our brains are wired to go right to what we think is the best answer or the most appropriate answer. Instead, the best way to prepare is to talk to people, talk to your family, talk to your supports, have a discussion with them, think about what's working, what's not working, what do we need, what are our strengths, what are our needs, and focus your time and your conversation in those areas. Engage in the process, and you're going to get good outcomes. So it happens organically. You know, if I engage you and I'm an assessor, I want to dig into that information that you start to share in a way that I know connects with what the assessment is, and we can create efficiency in process too. It's not a multiple choice questionnaire. So we're not going to go through it and you just tell me the answer. That would be us facilitating your self-administration of the tool. So again, to make sure that we're doing a good job, we have to utilize the process, rely on the training and expertise of these subject matter experts, and I think it can bring a more relaxed engagement that lends itself to better outcomes.
Well, I'm going to ask Karen
Yeah.
if she would to address that, because you're making assumptions when people are already asking questions that it is making them anxious. So let's hear from Karen as a family member.
You know, I have to say, Al, your answer reminds me a little bit of the debate that used to happen among doctors about whether to share test results with people because it would make some people anxious, and so maybe it would be better not to. And I think the consensus became let people choose what they would like to make available to themselves and to know and be informed if they want to be informed.
Sorry.
Our experience was it was very important for us knowing that the CAS is so much based on the inter-I, to see what those questions are, because many of them are very complex. They use words that we're not familiar with. The answers really require a lot of thinking that 1 hour certainly doesn't give us the opportunity to give the answers justice. Now we've set up a situation where people can access those questions, and not just those questions, but how they're scored. And not just that, but also how the scales are composed. So we have an idea of which questions might be more important than others in those scales. And so now we have a kind of inequity that we didn't have with the DDP2, where some people can access that information and other people can't.
Just to clarify that, you can, the IDD,
Mhm.
on which the CAS is based, not 100%, but to a very large extent, is available for purchase for anyone who has the funds to do so.
And Karen, just keep in mind as well that the CAS isn't completed only through the input that you provided, that it's also completed through the input from the paid supports, could be a direct care worker, a house manager, other paid supports, and supporting documentation. So, I hear you, and I appreciate that interest. And I, as I said, it's not our choice to not share. This is a tool that we're not able to to share for inter-RAI. But I think that the other challenge for us in ensuring equity is that we're leveling a playing field here. It sounds like you're extremely astute and well educated and informed, and perhaps you have an advantage because you purchased the manual. But I'm not sure that plays out in the completed assessment, because it's not solely completed based on your input alone. It is completed based on other sources of information.
And I'm going to add one more thing, because I'm not the technical expert that Al is on the instrument itself. But Karen, I do hear you. Rachelle, we do hear you. And I think one of the things we are acknowledging is that we can do better preparation. Rachelle, you mentioned it a little bit earlier about including family members and individuals in some of even our video and training to talk about the general areas that will present, so people will have an awareness. Because I do want to say, and I'm a clinician by background, but one of the things I would always say is it was very important for us when I'm having that conversation, if I ask you a question, to then see how much relevance that question has for you. And there were, as Al said, there are certain things I have to follow, and we hope, and we're working towards, and I know it doesn't always work for absolutely everyone, but the assessment should follow the person. Now, I say that in two ways. One, the assessment happens, so that person and that family member, like Karen, is telling us more where we should focus, that this is much more of an issue for the person they love than it is for another person. So someone might have very medically complex background that we really have to explore. Others, that might not be an issue at all. So I agree with you that we really do want to share that we're those general areas and have people prepared with the people that know them well and themselves to be open or be able to talk to them about those issues to the extent they can or to the extent they want to. I do want to emphasize that. So we're trying to make sure we're doing a better job. I think we can always acknowledge we have places to go, because we don't want people to be anxious and stressed about how much time or exactly what that question means. So I think we're working to get there in a better place, so families feel more prepared to answer and people feel more prepared to answer questions.
I appreciate that, Jeanne, and I appreciate your response. Thank you. I've run over my time, but I'm going to just have to adjust one more area, which is the summary documents that people get after the assessment. And we have had many, many questions from many different people that they are hard to understand. They don't know how to interpret them. when they look at the response that's documented, they don't know if it's the best response. Maybe there was a better response. They just don't know what to do with it. And their care managers at this point are similarly at sea. So it's sort of like the blind leading the blind, if you will. And is there a way that this, first of all, that the summaries can become more user-friendly for everybody, clearer? And also that, well, that's the most important thing. Is there a way to make it a clearer, more transparent process so that people can engage with it intelligently? Because otherwise, you're stuck. You don't really know if this is a right answer or wrong answer or not. And I know there's no right or wrong. Is it the best answer? Does it best capture the person? I'll avoid right and wrong.
Yeah, I don't disagree with you. We are looking at ways in which we can improve the personal summaries so that they do what is the intended goal, right? To facilitate discussion and understanding. So that's definitely something we're looking at as well.
Okay, glad to hear that. And I will pass this over to Carlene.
Okay, thank you, Rachelle. Very good discussion, guys. So to continue, hopefully, I wanted to talk with everyone about the uses for the CAS, how it will be used. I listened very intently because I heard it said and repeated that needs are needs. And I don't think anyone disagrees with that. But when we look at the summaries, we anticipate the scales, we anticipate the introduction of service ranges. We get a little worried and a little anxious about categorization, putting people in boxes, saying you are scale 1, you're in service range 2, et cetera, et cetera. You know where I'm going, guys. So what I'd like to know is right now, first, let's just start with right now, how it's being used. We hear that the CAS is needed for service request. If I request an additional service, if I want to change a substantial change in a service, that I have to have a CAS. We still have the DDP2 up and running. How is that CAS now, and those summaries and the scales, to the extent they are there, being used now when that service request moves through OPWDD? How is it being used? So that's, it's a quandary. I recently experienced that with the service request for my son. I wasn't sure how it was being used. I didn't think it would be a real major roadblock necessarily for what was being requested, because there wasn't a real difference between what he had and what he was requesting. But for someone where it is something different, something where, they're a little bit concerned that they may or may not get that. Suppose next week, I want to start examining the Crow process and putting him in line for a residential. You can have real concerns about how will the CAS be used, especially when you get to the point where it's going to be, the results are going to be isolated into categories. So I don't know if I can make that any clearer. Al, do you want to take the first crack at that?
I'm going to take one point,
sure,
Carlene, because I really appreciate, the question. And I think we saw in our presentations over the last couple of months that came up a lot. But the first thing I want to say is that when we talk about the new service authorization, CAS is required if you don't have a current CAS. So, and I know I saw in the chat, I can only follow the chat and pay attention so much. So I'm paying more attention, but I did see someone ask, and that right now that is every 2 years. So if that CAS hasn't taken place in 2 years and it's no longer current, we would ask for a current CAS. If it's current, your process is going to move forward. So that was the one clarification I could make. And you are right to point it out because he has a lot of the expertise that we'll probably volley back and forth. But Al, I know you've answered this question a few times, so I'll give you the mic, I guess, right now.
I have to admit, I'm lost in reading the comments, so I just need you to point me to the question.
Sure. I think it was that how
Well,
would
do
we,
you want me to reframe it?
Please.
Okay,
that'd
so
be
let
great,
me,
Carlene.
because it's really a couple of parts, okay? It's how it's being used now and how it will be used when it's fully rolled out.
Mhm.
Okay,
Yeah.
right now, how is it being used? It's a requirement for a
Mhm.
service change, right?
Yeah. Yeah.
So when you get it, you see your summaries, you see, sometimes I think you see the scales. How is that being used? What are folks looking at?
So as a starting point, Carlene, we have to remember that the CAS and this requirement to complete an assessment is a component of this comprehensive assessment and care planning process. So as much as you're experiencing this as, oh, your CAS is not current or you need a current CAS because you're requesting a change in service, we need to take a couple steps back and remember that step one is look at the CAS within this care management, care planning space. Think about the needs that are identified, expand those needs in the care plan if necessary, clarify those needs if they vary at all. But that is where the first step takes place. So when you're talking about how is it being used in service access and authorization, you know that the care plan, what we used to call the script for services, is what accompanies the request for services to the RO. And as a very first step in them looking at the appropriateness of services and supports, they're looking at the care plan. So step one is that. Now, when you just referenced caps and scales, look, this is something else we're working with the Alliance on. I'd love to hear from those guys, but I know you guys have some more questions for us. The caps and the scales are something that we're working on with providers and with CCOs because the scales and the caps are a support mechanism for caps focusing in on the assessment, looking at those areas that might be of high interest. The scales are something that can be also looked at a population level to understand the people that you're serving and look at trends or changes over time. So I don't want to commingle that with
Okay, could I stop
asked
you
about.
right there, Al? And I appreciate that answer. But before we bleed into the providers, and I understand it's a different question when we get to them. I've read your website. I took a look at it and I saw when you guys said service ranges will be created, okay? And service ranges will help the care manager identify kinds and types of services that are appropriate, okay? So, and I hear a lot that it will aid in the life plan process. But when you hear service ranges, you're talking about a numerical determination. Someone is going to be ranked. Someone is going to have high needs. Someone is going to have mid-range needs, lower needs. What is concerning is the categorization of that person as being one in one of those categories and how that person can be assured that they are properly categorized because it will have real effects on how that piece of paper is looked at and how when the service request moves through the RO, how that's done. So that's the real question and that's the real concern.
Carlene, what I think I hear you saying and others saying is, we don't want clinical expertise and information about the people we care about replaced by a score. And that is not what we plan on doing with that CAS service range. What it does help identify is, as you said, people that might have like needs, might have like support needs. So there's a range. There isn't a numeric score that says John is this score, Jane is this score, and it means they get this. This tells us in general, people that have the same needs, John and Jane might be the two people that have similar needs, would have similar ranges of support, but that's still essential to the care planning process. The service package is still driven by the person and the family to evaluate how that person gets best supported. Does that mean that someone is receiving ComHab? Would you prefer, or would they prefer to be in a day program for part of the week? Those things still have to happen. The assessment is sort of that, and I know some of you participated on our recent campaign of CAS and CANS informational sessions, where we talked about it's an outline, and even that service range is not a prescription. It is not an algorithm. It's an outline to say, in general, people with similar needs to this in this area wind up with these types of supports. And when you work with your care planning team, do you want to consider those supports? And some of you will say, John doesn't want to go to a day program. He doesn't enjoy it. It's too much on his balance to get in and out of transportation. It's too difficult. I'd really rather have somebody one-on-one with them. We're going to do some other level of support. And that has to be honored. That shouldn't be taken away, and that shouldn't be changed because we've now identified, similar to the DDP2, and I'll go back and and I know Dr. Pettinger talked about this several times over, like the ISPM score, that it's similar. It tells us it should do that job. The only thing I'll say about this is we're hoping because CAS takes in more information about the people you care about, we're getting a better idea of what a person's needs might be. And then you and the care team can plan them. So I'll take a pause out.
Supporting documentation remains very important to inform clinical decisions. So, the care plan, evaluations, not everything will live within this CAS, and there may be more to the story. And that's why I always like to bring it back as well to the care plan.
Okay, so I hear what you're saying. Then why do we rely so heavily on categorization, on tracking, on putting people in ranges when we say, okay, we have the flexibility. I hear you. We're going to look at the total person. We're going to look at the person as described in their life plan. That is what we want to animate. I understand that. But when you have a situation where you have some concerns, many concerns about the transparency, how this is being done, not seeing the questions, not having enough information now to know, okay, how hard do I really challenge this categorization? Maybe I don't, maybe I do, maybe I don't care if I'm mid-range, high range. Who would leave that out there? And how do we know that's all that's being done with this? It's very, there have been other jurisdictions, other states, I know you guys are aware, where there has been more rigidity built into the use of these. And Al, you know what I'm talking about.
Exactly. I don't
So
know. I don't know.
You're saying you're not doing it.
No,
you don't have
in fact, no, this is not automated decision making. There is a very human component that will absolutely remain. In fact, I wish I could channel Dr. Pettinger better because she used numbers and data that I just don't have off the top. But I know that there are hundreds of decision makers at DDROs around the state that all bring their experiences with them to the table to help inform decisions. From a starting point of service ranges, you're creating a mechanism to help ensure that people with similar supports, needs get access to and opportunity for similar supports and services. And then from there, you can move in either direction with interest or my needs are different. I know Michael Seereiter and I look similar. Okay? We look similar, but we may not have the same needs. Michael's got more hair than me. All right. But here's the thing. My point is that from a starting point, you might look at an individual in a service range and expect that they might utilize similar supports and services. But then through the care planning and other clinical information that's provided, you might learn Al's much more needy than Michael. Al's much more needy.
So
Carlene,
one more point before. I don't want to, I am not as familiar, but there are many who are signed on today who are in self-direction. It is my basic understanding that I believe it's the ISPM score is very critical to an evaluation of basically your PRA, your budget, how much money you get. Okay, so that's a direct correlation. Are you saying then if I'm in a service range and I find myself mid-range and that does not give me the budget that I think I should get, it's not the budget I got before, that, there is a way then now, what is the way for me now to get back to where I think I should be with that budget?
And I like that question, Carlene. I don't think we're quite there yet, as you know, and we've talked about that CAS and CANS will, directly, we don't know, so I won't guarantee you where it goes as far as PRAs. But I will always say this, that we know that due process isn't with the assessment. It wasn't with the DDP2. It is actually with your service authorization. And if you're not receiving the services that you think are indicated, then that's where you go through that process. And that is still available and that will never change. I wanted to bring back two important points about, you mentioned that service range. And one of the things I want to mention, or two things I want to mention, is Al touched upon it, but I loved what he said. It's also to keep us consistent. He's right. We have a lot of people on our system. I watched the chat. Many of you talked about how many different care managers, for good or for bad, because some people have had wonderful care managers, even when they've changed over. But we have staff turnover. We want to assure that we have a mechanism that helps those staff, all those different decision makers, when they get your package, make decisions and authorization decisions consistently. It makes it better for all of you. It expends less of your time and it gets you to your service points. And I know Dr. Pettinger talked about this, that it brings you, when we see it and it looks kind of in that range, we talked about it like in a typical service, what would be needed by people like John and Jane, and they're similar, that service package can go through. The second thing that I will mention is this is, and Al mentioned it, it gives us aggregate data about how to plan for people in our system. And I know not only are we talking about service ranges, but you will all see this. Even though we did our public campaign, we will be posting a recorded session as well as the questions on our website in December for you to all talk about or see. But Dr. Pettinger talked very clearly about having behavioral health measures, having medical health measures, and our population, I love it. She said it, best news ever, we're all growing older. And so are the people that we serve. That is wonderful. But that means their needs change. And this gives us information on a group level, okay, across all the people we serve. How do we prepare best? In 10 years, what does our service system need to look like? We all know this. We all know that as we age, myself included, I need to worry about how many times I go up and down the stairs. That will be, thank goodness, that will be a thing because the people we care about are aging. And that will tell us that we have to drive our system to be ready to support that. So that's just one small example. So I just want to recap that Carlene will use it, you're right, longitudinally to plan services appropriately, and two, to keep ourselves in check about how we make decisions. I hope that's a little helpful.
It's very helpful. And I did hear the doctor talk about those additional measures or modules.
Yeah,
and to me, it was very good news because it does make the entire inquiry look like it's more rounded in areas of particular concern to our population, behavioral and health.
Yep, and it mimics the DDP too.
But what I think all of us desire is some better understanding as you figure this out about exactly what's behind the curtain, how you're doing this. So we have some input into it. That's sometimes our frustration. And you said the word, and, I had not said it yet, Jeanne. You said due process. And, that's unfortunately, I could spend half the night talking with you about it, but I won't. But that's a problem when you do not have all the information, sufficient information you need to take a look and better understand a process that has such a monumental effect on you and your loved ones. It is required that you understand the inputs. I hear what you're saying. I hear you talk about the care planning, about the individual. A need is a need, but there's a reason you're doing the service ranges. There's a reason you will be doing the categorizations. and it will be one input. Even if I heard Al, it's not the only input. It's, it's layered. Every word, I heard it, but it is one. And I don't think anyone here would say it's not a substantial one. When you pick it up, when someone picks up that piece of paper and they see this is someone in a mid-range, it's going to leave an impact. It always does. We all remember what happened when we picked up and we looked at our grade reports. And I saw a B- instead of the B or the A I thought I was going to get. And so that's our concern, guys, that even though it seems to me you're working very hard to round this out and not to make it singularly focused on what could look like an exam, which may have, unfortunately, it won't be perfect. It'll have a lot of warts, probably. And you really need to measure the person. I know you're trying hard to do that, but that's the concern. So I'll shut up now and I'll turn it to Mike and Mike. Do you want to add anything here? I know there is some concern with providers also on this tiering or service ranges, because it will, when they figure it out, hopefully with your help, affect the rates that you will receive. So do you want to say anything to the group about that, or should I just move on?
Please talk.
I'll try. I'll try. I think it's going to be really important to make sure that this process works well, that we spend the time, energy, and resources trying to make this work so that we can eventually answer the question that you just asked, Carlene, which is, when we get to a point when we're actually ready to start thinking about shifting a system away from how it operates now to something later on, like that is in part based on CAS, does it accurately reflect the needs of an individual and the resources necessary to support that individual? That'll be the ultimate test of all this, right? This is where I would also give credit back to OPWDD, that we're trying to refine and build a new system and stand that thing up before we start tearing an old system down. And so that's going to be a really important factor of getting this right. We're not there yet, very clearly, I think, from lots of the comments that we've heard tonight. This is a process in general that I think screams for a technical assistance kind of project, a technical assistance capacity to support all of the stakeholders in this system and shifting from one mechanism to another. Families, self-advocates, care managers, providers all have an important role in this process. And from the family member perspective, I think it's really important to go in to the CAS process understanding what it is, how it works, being prepared for that to the degree that you can. And I don't mean in the same kind of way that was being suggested before of kind of studying up or boning up on how this works, but instead being prepared for the kind of interview and the kind of conversation that you're going to have with an assessor and what that means. There are lots of factors in there. I mean, we as families are, I feel, assessed to death at this point.
Mm-hmm.
Like, we are just exhausted of this, whether it's the self-direction circle meetings, or it's the life plan meeting, or now it's the CAS assessment. And like, it spins our head, right? Helping family members understand, you need to pay attention to this one. This one's going to matter in a few years as we eventually move to a different kind of system. You need to make sure that it's accurate, and you're going to need to refine it probably over a period of multiple assessments here. That's the kind of stuff that I think families are going to need to know and understand and be prepared for. I would love to see that done from a peer-based perspective. I think it's much more valuable for family members who have been through the process to be able to do that and support each other going through the process with guidance and support and inputs from OPWDD and providers and care managers and self-advocates who are also involved in this process as well. These are the kinds of things I think we need to be talking about if we're going to be making this work and building some of the trust necessary to make this work eventually later on. I could keep going, but I'm going to take a pause there and ask Mike if he wants to throw in anything as well.
No, okay. Thanks, Mike. I was nodding. You saw me nodding. I totally agree. One of my questions was going to be, but I think you've covered it in your answer. What can we do as this is rolled out, okay, so what mechanisms do we have to assess after it's rolled out, whether it's actually doing what it says it's going to do? How do we measure it? And we want to make sure that we take that measurement down to the smallest level possible for each individual. So I think Mike has just, outlined that. That's why it's so important to keep everyone involved and have everyone in this conversation. So I think that's, I had a lot of questions about the appeals, guys, but I think we've kind of covered some of them here. It's important, I think, going forward, when we get to that second stage that we're talking about, that there be a real thought going into how the appeal process will work and how individuals will have an opportunity to take a look at whatever those summaries and reports will look like when, you keep improving them out, and we still look at them and we say, that doesn't really look like my individual. Or I don't like this service range. I don't think I should be there. I think I should be somewhere else. Or they just plain got this wrong. We need to think about how those appeals should work and make sure that individuals have the right, I guess input and have the opportunity to do that. And maybe make sure they have the right assistance in doing that, whether that comes from the care managers or someone else, because folks may need some help in doing that. And I said enough. Karen, do you have any ideas along these lines? I know I've just babbled on.
There's so much to talk about. So there are a few things, the phrase "the need is the need" has come up a few times, and it sounds so straightforward. And one of the things that really concerns me is how a system is being set up to suggest that the CAS can determine what my brother needs. The CAS is fallible. The decisions that have gone into it are fallible. And that's not a reflection of anyone personally. It's because that is the nature of such a complicated process. It will not capture everyone's needs with the appropriate extent and implications and everything. There's just no way it can. And then when I hear that, well, it's possible to question a service authorization decision, but it is not possible to question how the CAS was done, or what tier a person is assigned to, or what can be included in that tier or not. I mean, there are all of these questions that really kind of are red flags for me. And so I think it's really important to allow, in a person-centered system, that people can just determine what they need. Now, if you need to do an acuity assessment, of course, it's mandatory for eligibility or whatever. That is one thing, but to use an acuity assessment also to suggest, well, there are patterns of what kinds and levels of services a person needs. I think we also should keep in mind that acuity does not align with services and supports in a couple of very important ways. Sorry, this is getting a little bit away from the due process question, but maybe I can bring it back to it. In terms of social integration, and in terms of learning skills to be more independent, these do not always align with acuity. Sometimes you need the same amount of staffing to help integration, regardless of whether a person has a score of 3 or a person has a score of 5 on their ADL scale. If you want to teach skills, I can cook dinner a lot more quickly than it takes me to teach my brother how to cook that meal. So I think we have to remember what is so important in terms of quality of life and where acuity doesn't capture it. And so I think we need to really be able to question the decisions that were made at every point in this process. I would hope that OPWDD would welcome sharing the thinking behind many of those decisions. And so we can work cooperatively, collaboratively, because I think there are many things that we are thinking about in terms of how those decisions impact the lives of the people who are getting services. I hope that's helpful.
I think it was. Mary, are we at time? We've got a little time, right? A few minutes?
Yeah, we have a few minutes more.
Okay.
I'm sorry. I thought something said 8. I apologize.
No, that's
No.
okay. That's all right.
8:30.
So, Karen, you've summarized, I think, 3 of the questions that I didn't get to. And I guess that's the concern, that we know that needs are needs, but sometimes those needs, as Karen just said, and I won't repeat it, do not solely depend on what is being measured by an acuity assessment. So that's I guess our concern. But one thing I wanted to bring out, because I think you guys feel strongly about this, and I want to give you a chance to explain it to us or explain to the larger group. We hear over and over again, we're doing this also because we want to make the whole system fairer. Okay. We want to make sure that, folks that are similarly situated are receiving or have the opportunity to receive the same, level and type of services, if that's what they want. Can you tell us how the CAS helps with that? So explain it to the folks that are here. Jeanne or
Sure.
Yeah.
Well, I think one of the places we think, and we've talked about this, so I feel like I'm a little redundant, but I think one of the things we hope is that assessment being and Al can jump in at any point, but being a consistent, trained assessment that is done objectively supports the idea that it's done equally and consistently for all the people we serve. So that's the starting point. And then from there, I think it does, because we value the information that it gleans, and it is larger and more comprehensive for the people we support. Again, we think it captures nuanced differences for the people that we, have in our system. So we've talked about those differences, being important to the people we care about and the people that we want to serve. So I think it does a better job of that. So going forward, I think it allows it to be more equitable. I think the process, and Al can talk more about this, that it is inclusive, that you are, and and we talked about this in our presentation, when the DDP2 happened, you're not necessarily a participant in that. You're not necessarily even aware. Neither is the person that, that has the developmental disability. People aren't included. We do make sure that this process is participating by family members, by people that know people well, the person themselves, and we do feel like that gives a better opportunity for us to support people in a better way than the way the DDP2 did, because there's voice to it. It also allows, and we talked a little bit about this, that assessment to be flexible to the person and to include because this came up and I'm very clear about it in our assessment, someone that might not have the verbal capacity to speak for themselves, to talk and meet with others and still meet with that person and include other information that gives us a fuller picture. So I think that's very important. So I think that's what we mean when we talk about moving to a sense of being fair and accurately representing all the people that we serve, regardless of their differences. It's going to happen consistently, and it's going to bring more information about them forward. So I'll stop there, Al, in case you have something.
No, I think you hit most of the points that I would raise as well. And an independent assessor is a good step in that direction. Having a comprehensive assessment that represents the person across service settings is a good step. I mean, think about how many I'd probably gather to say uh, hundreds of thousands of people are completing DDP2 because it's being done in every service setting by staff people who may not have the same interpretation, background, education, training, right? So there's so many aspects to compare and contrast that push us. But I think everyone on the call, as much as people have, as you've shared, many questions and concerns about this transition, would probably agree that we have a more robust tool that has more potential to better identify needs that people have, and that it's holistic and comprehensive, and that there's greater consistency and oversight and quality, and that it's being reviewed not just by the provider as accurate, but by the team as accurate, and that we have a process in place to fix things when go wrong. I mean, none of this was in place. And I was reading the comments earlier and saw, some of the remarks that were being made about DDP2 and what's happened as a result of some of the problems in our system. So I'm not going to stand here tonight and tell you this thing's perfect. It should be good to go. No one should have any concerns. I'm an advocate. I'm pounding the pavement too, raising awareness, and I want engagement and I want these discussions. I also want people to be open and collaborative in how we can find solutions together. So I appreciate what you've done tonight, New York City Fair. I appreciate you bringing people to the table to engage us in this conversation, to be open and allowing us to kind of share with you some of our thoughts. We've got more work to do. We have
Al,
more
can I
work to
just,
do.
I just want to interject because we're coming to the end of this. And if I can sum up in a very crude way, and I apologize, that what comes through in a general way is that the care manager, who is the primary conduit for families and self-advocates to getting this done, has got to be robust. They must be able to communicate all the things that you say and make them true so that they're not just theoretical. They are actually happening for people. And also that there still is a tremendous lack of transparency about many parts of this procedure. And we need to keep working on that. And I think one of the ways to do it is that we, not just in a situation like this, which we've set up, have stakeholders in the process all the time. You have to work with the providers, which I believe you're doing. You have to work with self-advocates, and you have to work with families to find out what the user experience is and what the outcomes will be for people's budgets and for rate setting, which is where the rubber meets the road. And that's my editorial, and I apologize if I've offended anybody, but we are very close to being finished. If our moderators or anybody wants to say anything more, please go ahead. And I'll be quiet now.
I'll just add one last closing thought. So we did this roadshow for about a month and a half. In fact, we're doing 2 webinars tomorrow. And it was recorded, and we're going to put it on the website. And what I really encourage everybody to do, if you were not able to attend some of the sessions, either live or in webinar, is to watch the recording, because so many of the questions raised tonight are addressed in the webinar and in much more detail than we could ever do in a forum. So we really do encourage everybody to reach out to the website, watch the recording, and see if they can feel more comfortable with the answers that are laid out in that presentation. So we really do encourage that.
Anyone else?
Yeah.
Kevin,
One last thing.
Yes, please.
One
Rachelle.
last thing, if I may. First, I do want to thank everybody. I think everybody came in very thoughtful, very prepared. And we're willing to engage perhaps with some challenging material and questions from us. I think this opens the door for additional collaboration. I think that at this point, you should see that we have ideas to offer, that we want to be part of this process because it's going to affect every part of our loved ones and our lives. And so it's another appeal for inclusion of individuals and families in this ongoing process of developing the CAS and developing the workflows around the CAS and developing the education around the CAS and everything else and the use of the CAS. And we do appreciate that you want to have individuals and families be more comfortable with that process. That's come through loud and clear. But in order for that to happen, our concerns really need to be comprehensively integrated and addressed. So I'm going to end on that appeal.
I just want to say, Kevin, if you could send in your question, because we do have to end at this point, to info@nycfair.org. We will make every effort to get you an answer as best we can from those who can answer. And now I'm going to say, I guess if no one else has anything to say, good night. And thank you all for showing, and to our panelists, thank you very much for taking the time. We may indeed return to this as we find out more and hear more from everyone. And thank you.
Thank
Good
you,
night.
everyone.
Thank
Have a
you.
good night.
Good
Everyone.
night.
Thank you.